we are going to take you through advancements in posterior segment today. And you all know Dr. Prathibha. She has conducted basics in anterior segment last Saturday. So those who are new, for your information, Dr. Prathibha has more than 10 years of experience, and she is cataract as well as VR surgeon practicing in Inipigo Eye Hospitals in Ratnagiri, Maharashtra. She has done her education from JNMC Bangalore, KIMS Hubli, and Netradhama Bangalore. So without taking much of your time, over to you, Dr. Prathibha. And thank you for accepting this invitation.
Thank you, Pratik sir. Good evening, everyone. I'm Dr. Prathibha here. I'm assuming that I'm speaking to most of the counselors here who are involved in both cataract as well as the retina counseling. As retina counselors, you need to have few things which are more important than selling the product as you need it in the cataract, as for the cataract. Retina, you need to have close association with your doctor, especially the retina specialist, because the procedures in retina are not as simple as they are in cataract or glaucoma or in refractive procedures. In retina, you need to have as a counselor, you need to have lots of patience more than your doctor, as well as patience more than your patients, because you need to bridge the gap between the doctor and the patient. Okay. And every time the patient is coming to you, he's seeing common faces. One is of the doctor and one is of yours. So in retina, the most important thing is, apart from diagnosis and treatment, is the frequent follow-ups which happen more frequently than in any other surgery, because the patient may be lifelong patient for you, and he may be just as a extended family to you. So you need to talk to the patient very carefully every time, cross check the details, what has to be spoken to the patient, and especially talk to your doctor before talking to your patient, what not to talk about also. Okay. So let's start. The retinal procedures are very extensive. Okay. Diagnosis itself is very extensive. The diagnosis also takes time. The patient has to spend minimum 2 to 3 hours every time he comes to the hospital. So from receiving him in the reception to the time he comes into the doctor's chamber, where he comes with dilatation, the dilatation process may take really extensive time. Okay. So you need to have that communication with the patient as well as the attender. And the patient, whenever we see as a retina person, the patient may be above 40 years, and they may be having diabetes and hypertension. They may come early to you in the morning and they may end up going in the afternoon. Okay. So you need to have some sort of communication with them every 1 hour or 2 hours, telling them that this is what will be done to you next. And now at present we will just check your vision, or we will dilate you. The dilatation process will take so much of time. The doctor is seeing so many patients before you, so your entry is at this time. So you need to communicate to them from time to time, because the retina patient stays in your OPD for more than 2 to 3 hours. Okay. So the doctor has as a retina specialist, we have lots of armamentarium with us for the diagnosis as well as for the treatment part. First, let me tell you the investigations which we commonly do in posterior segment, that is especially related to uvea as well as retina or the optic nerve. First thing, which is the commonest test which we do, is fundus fluorescein angiography. Second most common thing is B scan. Third is optical coherence tomography. Now we have a recent advancement where the angiography and the OCT are combined, and we called it as optical coherence tomographic angiography, that is OCTA. Then the treatment protocols, we have laser, which is the OPD procedure, and it is the most commonest procedure which we do. And then second comes the vitrectomies. All as a counselor you need to know is how does the vitrectomy machine look like, or what are the surgery your doctor does, what are the things involved in your surgery. Especially you need to know, because you are writing the consent form and you are writing the diagnosis in that, so you know that the doctor is going to use these things. So you yourself also should know how it looks or how does it appear on the surgical table. This is the FFA machine. The machine looks like this. The machine has a chin rest, okay, where the patient will keep the chin, and we take the photograph through the camera, which is there on the other side of the angiograph. Once the during the angiography, the patient comes usually empty stomach, preferably empty stomach, nil orally. If the patient is diabetic, we tell them to take half dose diabetic medications. Okay, and then if there is, we always take a questionnaire before doing the angiograph regarding any allergy towards sulfa drugs or any other drugs for that matter. For angiography, the procedure itself will take at least 10 to 15 minutes or maximum 20-25 minutes. But the anesthetic backup has to be there, because usually the allergy which happens may be mild, like itching or just discoloration of skin and discoloration of urine. But apart from that, some patients may have severe allergic reactions. At that time, you need an anesthetic backup who can give anti-allergics and steroids if required. The angiography, once it is taken, it is a black and white image which appears like that. However, like how it is seen here, it is a black and white image. It is not a color image. As a counselor, what you need to know is, once the reports are always given to the patient. So if the patient is asking you something in detail, always look at the pictures which is available with you. You can look at the diagnosis what your doctor has written. If you're not understanding something, then you can as well use the photographs which are available and explain it to them exactly the same way the doctor has explained to him. As I said, most important thing is always taking the consent before doing the procedure. This is the normal picture, like FFA picture, the picture which you're seeing on your left side. This is the normal picture where it is seen as, the dye is seen as a white color dark thing, and the background is seen somewhat as grayish color. So any abnormality, this is normal. Any abnormality is usually seen as hyperfluorescence, or very dark area hypofluorescence. So like you need to know, at least as a counselor, you should know that is this picture normal or abnormal. That's all you need to
Hello.
know. Ah,
Hello.
sir.
I'm sorry to interrupt you, ma'am. Can you please mix it, I mean, in English and Hindi? There is a
Yeah,
request.
yeah, yeah, yeah. Sorry. Yeah, I'll do that.
Thank you.
Yeah, yeah. एंजियोग्राफी के पिक्चर्स ऐसे दिखते हैं यूजुअली, सफेद और थोड़ा काला जैसा दिखता है। ये नॉर्मल पिक्चर है जो आप लेफ्ट साइड में दिख रहे हैं। और जो अबनॉर्मल पिक्चर है वो उसमें हमेशा लीकेज रहते हैं, या फिर हाइपर फ्लोरेसेंस, लाइक बहुत ही ज्यादा व्हाइट दिखता है या फिर बहुत ही ज्यादा काला दिखता है। एज अ काउंसलर आपको सिर्फ इतना पता रहना चाहिए कि ये नॉर्मल पिक्चर है कि अबनॉर्मल पिक्चर है। ज्यादा लाइक आपको डायग्नोसिस ऑलरेडी पता रहता है, मगर फिर भी आपको भी जब पेशेंट को बताते वक्त अगर मुश्किल हो रही है, तो आपके पास ये पिक्चर्स हमेशा रहते हैं। तो वो देख के और डॉक्टर से डिस्कस करके आप उनको समझा सकते हैं। नेक्स्ट कम्स द ऑप्टिकल कोहेरेंस टोमोग्राफी और द ओसीटी। ओसीटी अभी बहुत कॉमन है, हर किसी के पास ओसीटी रहता है। ओसीटी एंटीरियर सेगमेंट, पोस्टीरियर सेगमेंट, कॉर्निया, like refractive procedures, everything is combined in one machine nowadays. Previously we used to have separate OCT like only for retina, but now you have all the combined features for glaucoma, cornea, and anterior segment, as well as refractive workup, as well as रेटिना। ऑप्टिकल कोहेरेंस टोमोग्राफी की एडवांटेज ये है कि एंजियोग्राफी में जैसे हम सुई डाल के उनको डाई देते हैं, यहाँ पे हम कोई डाई नहीं दे रहे हैं, फिर भी हमको अच्छा सा एक कलरफुल पिक्चर मिलता है। तो इसलिए इट इज नॉन इन्वेजिव और बहुत ही फास्ट हो जाता है। एंजियोग्राफी 20-30 मिनट लगते हैं, मगर ओसीटी 5 मिनट्स या मैक्सिमम 3 मिनट्स में हो जाता है। और ओसीटी का एडवांटेज ये है कि ये मशीन कोई भी यूज कर सकता है, और हर टाइम पे हमको सेम स्कैन्स, इट इज रिपीटेबल, इट इज वेरी एक्यूरेट, इट इज कंसिस्टेंट, एंड हर बार हम उसको पिछली बार से कंपेयर करके एक रिपोर्ट भी दे सकते हैं। Whereas angiography is a one time procedure, so if I have to see, like after 1 month, if I have to see how is the retina looking, I will have to repeat the angiography. But whereas in OCT, it is repeatable, it is easy, and it is non-invasive. So OCT is much for repeated follow-ups when the procedure of choice is OCT. Okay, angiography is a one-time procedure which we do only at the time of diagnosis. OCT का पिक्चर ऐसा दिखता है. You don't have to worry. आपको like you don't have to worry about the details, but all you need to know is this is how the OCT looks. Normal OCT looks. There is always a depression in the center, and the lower part, which is the yellow part, which should appear very straight as it is appearing here, and the central part where the vision is maximum, there is a depression like this. So that is the normal OCT ऐसा दिखता है, ये आपको पता रहना चाहिए. Anything, any deviation or any changes would be mentioned in your report, and that is what you have to just explain it to the patient. ये कलर पिक्चर्स में भी आते हैं और थोड़े मशीन्स ब्लैक एंड व्हाइट पिक्चर्स भी देते हैं. सो डोंट गेट कंफ्यूज्ड. इन ऑल द पिक्चर्स इट इज द सेम. इन एवरी मशीन यू कैन हैव द कलर ऑप्शन एज वेल एज द ब्लैक एंड व्हाइट ऑप्शन. नेक्स्ट कम्स द बी स्कैन. बी स्कैन रेगुलरली सबको पता है कि हम मैट कैट में करते हैं. when the cataract is very hyper mature, brown cataract, and you're not able to see the retina, you do B scan. But B scan in retina, we do it in uveitis, where we have vitritis, dense vitritis, and we are, as a retina person, I am not able to see the retinal blood vessels, and as well as there is bleeding inside the eye, especially in diabetic retinopathy patients. Okay, or else there is a patient who is having sudden loss of vision because of retinal detachment. I need to know the details, how the retinal detachment, where all it has happened overall. So that is when I will do the B scan. B scan is also non-invasive. बी स्कैन में हम 3 तरह के स्कैन्स करते हैं. द वे आई होल्ड द प्रोब, मैं जैसे प्रोब पकड़ूंगी वैसा वो इमेज देता है. तो मुझे एक्सियल इमेज चाहिए तो मुझे प्रोब सीधा पकड़ना पड़ेगा. ट्रांसवर्स इमेज चाहिए तो मैं उसको हॉरिजॉन्टली पकड़ूंगी. और अगर मुझे लॉन्गिट्यूडिनल इमेज, ये लाइक यू डोंट हैव टू रिमेम्बर transverse scan, axial scan, or longitudinal scan as a counselor, but you need to understand that there is a B scan, and the way I position the B scan probe, depending on that I get different images, especially 3 different images. Okay, this is how a normal B scan looks. ओके ये अभी बी स्कैन का रिपोर्ट अगर आपके पास है और आपके पास प्रिंट आउट है, आपको इतना पता होना चाहिए कि विट्रेस बहुत काला दिखता है. द रेटिना हियर इज अटैच्ड. दिस इज द ऑप्टिक नर्व हेड. दिस इज द बेस्ट इमेज विच यू शुड बी सर्चिंग फॉर इन योर रिपोर्ट. ये सब नॉर्मल है तो यू कैन आराम से say the B scan report is normal, and otherwise also the reporting would have been done. Okay, ये रेटिनल डिटैचमेंट में ऐसा दिखता है. लाइक आई एम जस्ट ट्राइंग टू गिव यू अ एग्जांपल दैट इन बी स्कैन रिपोर्ट अबनॉर्मल कैसा दिखता है. दिस इज हाउ द अबनॉर्मल बी स्कैन वुड लुक. यहाँ पे रेटिनल डिटैचमेंट है एंड द विट्रियस इज हैविंग सम ओपेसिटीज. ओके, द विट्रियस इज नॉट क्लियर. ओके, सो यू शुड नो दैट दिस, ऐसे रिपोर्ट जब आपके पास है, एटलीस्ट डोंट से दैट दिस इज नॉर्मल टू द पेशेंट. ओके, ये विट्रियस हेमरेज है, मतलब विट्रियस कैविटी में खून भरा है. So the central cavity is not dark as I showed you in the normal picture. Here it is like showing white, एक white background की तरह दिखता है. उसके पीछे ये जो detachment है, ये choroid है, ये choroid में भी detachment है इस picture में. ठीक है, you don't have to worry really about the details. Okay, all you need to know is when you're talking to the patient, keep the reports in front of you and then talk to them, because they also should know that you understand the details. ये अभी नया मशीन है जो मैंने बोला था कि सब प्रीवियसली वी हैड टू डू एफएफए सेपरेटली एंड ओसीटी सेपरेटली. नाउ वी हैव द एडवांटेज, एटलीस्ट फॉर फ्यू डिजीजेस, where we can avoid giving angiography like fluorescein dye to the patient. And similarly, just like how I said previously that angiogram मैं हर बार नहीं कर सकती, now because of this machine OCTA, anybody who has this machine has the advantage of doing it every time just like a OCT. This is non-invasive, but this can be invasive also. Like I can still give injection fluorescein dye and still I can get the pictures if required. OCTA picture ऐसा दिखता है. I told you, right? This looks exactly like angiogram report as well as the OCT report. Both are combined in this machine, so that is why it is expensive also. Okay, now investigations I told you, like OCT, B scan, and FFA. Okay, so treatment part, the most common treatment which we do in retina OPD is the lasers, because it is a one day procedure, or on spot treatment can be done. So in OPD we do usually do prophylactic laser for retinal holes and retinal tears, or we do laser for diabetic retinopathy. Like laser करने के लिए all that I need is the diagnosis to be made, and especially if angiogram reports are available, and on if OCT the fovea is normal, laser can be done as a OPD procedure on spot. Okay, तो laser के लिए भी consent form लगता है. Okay, just like in angiogram we take the consent form, lasers के लिए भी उनका उसका खुद का, हर एक पेशेंट के लिए लेजर करने से पहले डायलिटेशन चाहिए. Okay, and then we need to take the consent form में कौन सा लेजर कर रहे हैं वो लिखा रहना चाहिए. एंड लेजर जिस पे कर रहे हैं उसका सिग्नेचर लगता है. एंड देन पोस्ट लेजर क्या क्या तकलीफ हो सकती है, लाइक द विजन विल बी ब्लर फॉर सम टाइम, एंड देन वट एवर विजुअल रिकवरी will happen eventually. It will not happen because of the laser that we are doing immediately. Okay, that has to be mentioned. जो भी कर रहे हैं, जिस चीज के लिए कर रहे हैं वो मेंशन करना चाहिए. विजन यूजुअली इफेक्ट नहीं होता है लेजर से, जो नजर है वो बच जाता है लेजर से. ठीक है. और types of lasers are there now. We have green yellow laser, then we have diode laser. Okay, and then now we have micropulse laser. So there, depending upon the machine that is available in your institute, you need to mention that this is the laser which we are using. Every laser has its own frequency and wavelength that has to be mentioned sometimes. Okay, एंड लेजर करते वक्त यूजुअली आपके डॉक्टर्स जो पैरामीटर यूज करते हैं लेजर मशीन पे, वो यूजुअली मेंशन किया रहता है नोट्स पे. वो भी मेंशन करना जरूरी है कंसेंट फॉर्म में. ठीक है, कि ऐसा लेजर होने के बाद कि ऐसा ऐसा लेजर हुआ था, इतने स्पॉट्स लगे थे, इतना पावर यूज किया था, इतने टाइम इतने ड्यूरेशन के लिए दिया था. दैट हैज टू बी मेंशन्ड. ओके, लेजर हम रेटिना में दो ही चीजों के लिए यूज करते हैं. एक तो रेटिना में जब होल होते हैं या फिर लैटिस डिजनरेशन होता है या फिर रेटिनल टेयर है, एंड देन पोस्ट सर्जरी अगर थोड़ा सा लेजर हमको और थोड़ा लेजर देना है तो हम वहां पे यूज करते हैं लेजर. एंड लेजर फॉर डायबिटिक रेटिनोपैथी इज द मोस्ट कॉमनेस्ट लेजर विच इज डन. ओके, ये देखिए, दिस इज द रेटिनल होल. इफ यू कैन फेंटली सी, दिस इज द रेटिनल इमेज. ओके, दिस इज द पेरिफेरल इमेज, दिस इज द रेटिनल होल. तो होल जब होता है, whenever there is a retinal hole doesn't mean that the retina is detached. The retinal hole is detected, and once the retinal hole is detected, all that we can do is, हम जो कर सकते हैं वो retinal hole retinal detachment में ना हो, उसके लिए हम उसके आगे पीछे laser spots देते हैं. laser spots देने के बाद ये जो आपको yellow spots दिख रहे हैं, the laser spots will appear like this. usually हम 3 या 4, इससे ज्यादा देते हैं. यहाँ पे 2 दिख रहे हैं आपको, यहाँ से हम 3 या 4 सर्कल्स ऐसे बनाते हैं और क्लोज और थोड़ा क्लोज बनाते हैं. अभी स्टार्टिंग में जब हम लेजर फ्रेश रहता है तो वो व्हाइटिश या येलोइश दिखता है, बाद में वो पिगमेंटेड हो जाता है. सम ऑफ द इंस्टीट्यूट्स गिव द पिक्चर्स ऑफ द लेजर बिफोर लेजर, आफ्टर लेजर, एंड after 2 weeks of laser. They do give the pictures so that there is a evidence that laser किया था ऐसे बोल के. Okay, this is lasers in diabetic retinopathy. You need to know that laser in see, the laser usually in retinal tear is done in single sitting. Okay, single sitting. But usually अगर दोनों आंख में है प्रॉब्लम तो हम एक आंख का एक बार करते हैं, दूसरे आंख के लिए एक 3 दिन या फिर एक हफ्ते के बाद बुला लेते हैं. But sometimes if for very small holes you can do both the eyes together at the same sitting. Okay, रेटिनल लेजर्स इन डायबिटिक रेटिनोपैथी, यहाँ पे आप देखेंगे कि दिस इज द ऑप्टिक नर्व. ओके, these are the blood vessels. लेजर जो डायबिटिक रेटिनोपैथी में करते हैं उनमें स्पॉट्स बहुत ज्यादा लगते हैं, लिटरली नियरली अराउंड 2000 to 2500 स्पॉट्स लगते हैं. when we have to give so many spots, we can't do it in one sitting. We usually divide it as 4 sittings. एक नेजल क्वाड्रेंट के लिए, एक सुपीरियर क्वाड्रेंट के लिए, एक इंफीरियर क्वाड्रेंट के लिए, एक टेम्पोरल क्वाड्रेंट के लिए. एक आंख के लिए 4 सिटिंग्स तो लगते हैं, तो दोनों आंख के लिए 8 सिटिंग के, लाइक इफ यू डिवाइड इट, यू कैन डू इट बोथ द आईज 1 क्वाड्रेंट. लाइक एक आंख के लिए 4 सिटिंग लगते हैं, तो दोनों आंख के लिए 4 सिटिंग में आप दोनों आंख में एक एक क्वाड्रेंट कवर कर सकते हैं. बिकॉज यू नीड टू अंडरस्टैंड दैट जब हम लेजर करते हैं थोड़ा दर्द होता है, एंड देन फोकसिंग में प्रॉब्लम होता है, and then the reaction for the laser is also there, so you can't give all the spots together at a time. Okay, so लेजर प्रोसेस, लाइक अगर एक डायबिटिक रेटिनोपैथी पेशेंट को अगर हम लेजर बोल रहे हैं, तो हफ्ते में एक बार या फिर 4 दिन में एक बार आके वो 4 सिटिंग्स करके 4 4 दिन में के गैप में करके, like at least over 3 weeks or over a month, the process is completed. Okay, the laser effect will not come immediately. The effect of the laser will come over 3 weeks. Okay. तो इसीलिए लोग क्या, like most of the doctors, what they do is whatever they want the laser effect, they do it in extensively in the first 1 or 2 sittings. The third sitting is done after the response of the first and the second sitting is seen. Like usually second दूसरे महीने में करते हैं, पहले महीने में दोनों आंख में 1 या 2 सिटिंग करेंगे, उसका रेस्पॉन्स देख के तीसरा सिटिंग और चौथा सिटिंग नेक्स्ट महीने में करते हैं, बिकॉज यू द डॉक्टर ऑल्सो गेट्स द एडवांटेज दैट यू नो, ओके फाइन, दिस इज हाउ मच मोर रेस्पॉन्स आई वांट फ्रॉम देम, तो स्पॉट्स बढ़ा सकते हैं वो तीसरे और चौथे सिटिंग में. दिस इज द लेजर मशीन. सी लेजर मशीन ऐसा दिखता है. एवरी इंस्टीट्यूट हैज देयर ओन वे ऑफ डूइंग लेजर. मोस्ट ऑफ देम डू इट इन द, लाइक यू नो, slit lamp based is supposed to be the safest one, or you know, more convenient one. The only thing is it is like you know, यहाँ पे हमको एक एक्स्ट्रा लेंस यूज करना पड़ता है फोकस करके लेजर करने के लिए. तो एंड द लेंस इज प्लेस्ड ऑन द पेशेंट्स कॉर्निया. तो पेशेंट को कोऑपरेटिव होना पड़ता है, बिकॉज एक कोई चीज हम उसके आंख के ऊपर रख रहे हैं, तो दैट विल कॉज लिटिल डिस्कम्फर्ट. सो पेशेंट हैज टू अग्री फॉर द प्रोसीजर वेदर ही वांट्स फॉर द स्लिट लैम्प और ही वांट्स टू गो फॉर द आइडियो लेजर. ओके, सो लेजर मशीन ऐसा दिखता है. द डॉक्टर सिट्स ऑन दिस साइड where the binoculars are seen, and जहाँ पे भी चिन्ह है, as you are seeing here, the patient sits on the other side. Okay, so there is a band which supports the head of the patient. The lens is held by the doctor from the left hand, and the laser shots are given through the machine's joystick. Okay. Now the laser machine, as I said, there is slit lamp based as well as IDO based. Like मतलब हम जो indirect ophthalmoscopy OPD में करते हैं, उसी procedure में the same the optic fiber रहते हैं जो IDO को connected and the machine is connected with that. तो ये the doctor is using only the 20D diopter or the 30D diopter, or and the patient is more comfortable here because the patient is lying down or is in the reclining bed. सेटिंग्स यूजुअली दोनों स्लिट लैम्प बेस्ड और आईडियो में सेटिंग सेम रहते हैं. द ओनली थिंग इज हियर फोकसिंग में, लाइक बिकॉज वी आर यूजिंग लेंस देयर, स्लिट लैम्प में हम पेशेंट का आंख पकड़ के करते हैं, वहां पे स्टेबिलिटी ज्यादा रहता है. हियर इन आईडियो द पेशेंट हैज टू बी मोर कोऑपरेटिव. द पेशेंट हैज टू लिसन टू द डॉक्टर वेयर टू लुक, एंड ही हैज to keep looking at that position for some time before the shots are completed. दिस इज जस्ट अ वीडियो, द ऑडियो प्ले नहीं होगा, जरा वीडियो देख लीजिए. यहाँ पे ये रेटिनल टेयर है, तो टेयर के आगे पीछे लेजर कैसे करते हैं वो दिखाया है. नेक्स्ट विल कम टू द ओटी प्रोसीजर्स और द जो सर्जरीज होते हैं रेटिना के. आई थिंक बेसिक रेटिना टॉक में वो हुआ है कि what are the types of surgeries which are done in the posterior segment, like whether it is retinal detachment or diabetic vitrectomy or vitreous hemorrhage removal or ERM removal, macular hole surgery. You know, ये सब चीजें आपने सुनी होंगी. जो रेटिना के डिपार्टमेंट में ज्यादा काम करते हैं उनको ये सब टर्मिनोलॉजीज इजी रहते हैं. बट ओवरऑल posterior segment के लिए the most commonest surgery is the vitrectomy. Like in every surgery we do a vitrectomy. तो vitrectomy machine ऐसे दिखते हैं. Okay, usually it is like we need a gas to make the cutter move. So एक सिलेंडर अटैच रहता है मशीन को, और ये विट्रेक्टमी मशीन के साथ कटर आता है और पोर्ट्स आते हैं. ओके, तो विट्रेक्टमी मशीन उतना बड़ा है, मगर उसके जो अटैच्ड प्रोब्स रहते हैं वो प्रोब बहुत छोटे रहते हैं जिससे हम अंदर जाते हैं. सो द प्रोब्स और द पोर्ट्स कैन बी ऑफ डिफरेंट साइज. प्रीवियसली वी यूज्ड टू डू 20 गेज. 20 गेज मतलब थोड़ा टाका लगता था. ओपनिंग 20 गेज का बड़ा रहता है, मोर देन 1 1.2 mm रहता है वो। तो 20 गेज से शुरू होता है, 20 गेज, नाउ वी हैव 23 गेज, नाउ वी हैव 25 गेज एंड 27 गेज। सो ऑल यू नीड टू रिमेंबर इज एज अ काउंसलर 20 गेज में टाका लगता है, 23 गेज, 25 गेज, 27 गेज में यूजुअली टाके नहीं लगते हैं। ओके, दे आर सेल्फ सीलिंग वुंड्स। ओके, तो डिपेंड, यहाँ पे आप देख रहे हैं ये पिक्चर है, ये ब्लू कलर का पोर्ट है, दिस इज 25 gauge, I think. So depending upon whether it is 23 gauge, 25 gauge, or 27 gauge, the color of the port, color of the ports changes. So during surgery, if you are giving a live demonstration to the patient, you can understand that, okay, fine, the doctor is using 27 gauge or 25 gauge, depending on the color of the port. Okay, the ports are made like this. What do these ports do? ये ports हम 3 port compulsorily बनाते हैं जिससे हम अंदर जा सके. Okay, सो दिस इज ऑल यू नीड टू नो। अगर 3 पोर्ट बनते ही हैं हर रेटिना सर्जरी में, तो एक लाइट के लिए है, एक कटर के लिए है, और दूसरा एक इन्फ्यूजन के लिए, जो आंखों को स्टेबिलिटी देने के लिए हम पानी यूज करते हैं या सलाइन यूज करते हैं। ओके, दिस इज द बेसिक थिंग दैट यू शुड नो। ये विट्रेक्टमी कटर्स है और इल्यूमिनेशन एंडो इल्यूमिनेटर्स है जो रेटिना सर्जरी में हम यूज करते हैं। ये बैंड है, ये बकल है। Okay, this is how the band buckle band look like. This is how it looks. ये हम यहाँ पे एक सपोर्ट की तरह यूज करते हैं उसको आरडी सर्जरी में। सो एटलीस्ट यू शुड नो दैट दे आर वाइट, ट्रांसपेरेंट एंड दे आर इनर्ट, दे डोंट कॉज मच रिएक्शन। ये आंखों में लगता है, वो कैसे बिठाते हैं वो आप देख सकते हैं। ओके, these are all not removable, and at the same time they don't dissolve also. Okay, once it is put, it remains in the eye. I'll just show you a small vitrectomy video. Vitrectomy का वीडियो है जो कैसे करते हैं। जैसे मैंने बोला कि एक लाइट का सोर्स रहता है, एक कटर के लिए जाने के लिए सोर्स रहता है। तो ये रेटिनल डिटैचमेंट है। तो हम विट्रियस निकालते हैं। विट्रियस निकालने के बाद गैस या फिर ऑयल यूज करते हैं ताकि रेटिना अटैच हो सके आई बॉल के लिए। उसको सील करने के लिए फिर से हम लेजर यूज करते हैं। अभी जैसे मैंने बोला कि विट्रेक्टमी के बाद हम रेटिना जो डिटैच रहता है या जो सरका हुआ पर्दा रहता है, उसको बिठाने के लिए गैस या फिर ऑयल यूज करते हैं। ओके, तो जब भी हम गैस यूज करते हैं एक पोजीशन मेंटेन करना रहता है, ऑयल या फिर गैस के लिए भी, क्योंकि गैस जो है हम जो यूज करते हैं कॉमनली C3F8 या SF6 जो बोलते हैं हम, 2 गैसेस कॉमनली यूज्ड है। तो जब भी गैस यूज करते हैं उसका इफेक्ट, मुझे गैस का इफेक्ट जो चाहिए, दैट आई वांट इट ऑन द मैक्यूला और आई वांट इट मैक्सिमम ऑन द फोविया। तो इसलिए पोजीशन लाइक हेड डाउन पोजीशन मेंटेन करना बहुत जरूरी है। वो पेशेंट जब चाहे तब नहीं मेंटेन कर सकता। व्हेन लाइक टुडे अज्यूम आज सर्जरी हुआ है, तो पहले 10 दिन, पहले 14 दिन बहुत इंपॉर्टेंट रहते हैं। तो फर्स्ट 10 to 14 days are very important where the patient should be told to maintain the head rest position, head down position for maximum time in a day. Like you can't tell him to maintain for 24 hours, but over 24 hours he has 75% at least he has to remain head down, because we want the effect of the gas or the oil maximum on the fovea or on the macula. Okay, सिलिकॉन ऑयल अगर हम गैस यूज कर रहे हैं तो गैस अपने आप बॉडी से क्लियर हो जाता है 10 या 14 दिन में। मगर जब भी हम ऑयल यूज करते हैं सेपरेटली, एक 3 महीने के बाद हमको ऑयल निकालने के लिए फिर से सर्जरी करके उसको निकालना पड़ता है। Whenever there is oil put and if you are able to take a photograph, ये जो रिफ्लेक्स दिख रहा है, this is typical of silicone oil. Okay, ऑयल डला हुआ है कि नहीं आंख में, वो देखने के लिए either you can do a B scan or you can take a fundus photo. Okay. Next, I'll come to the most commonest thing which is done in every clinic now or in every hospital, that is anti-VEGF injections, intravitreal injections. Intravitreal injections are nothing but they are a small dose of injections which are given inside the vitreous. Okay, so intravitreal injections में we know that the most commonest one is Avastin now. Avastin या फिर bevacizumab हम जो बोलते हैं, this is the most commonest one because it is though it is not Food and Drug Association approved, it is easily available and cost effective ज़्यादा है, and one vial can be used for more than 5 to 6 patients or 5 to 10 patients at a time. So the cost of buying it for the hospital is also cheap, as well as distributing it to some 5 to 6 patients at a time also becomes affordable. So pricing कम होने की वजह से though it is not a FDA approved, that is, this is not a standard treatment, but it is over the drug, like it is experimented and it has been used for last 15-20 years, and it is as safe, but still not FDA approved for eye procedures. Okay, the FDA approved drugs are ranibizumab. इसके brands अलग अलग है, different companies ने इस molecular का नाम अलग अलग रखा रहता है. Most commonest one is the Accentrix. The advantage of ranibizumab is that it is FDA approved, as well as the way it is marketed, like single dose, एक patient के लिए एक ही drug available, मतलब एक वाइल अवेलेबल रहता है, तो यू कैन यूज सेफ्टी प्रोटोकॉल ज्यादा है, रिस्क ऑफ एंडोफ्थाल्माइटिस गेट्स रिड्यूस्ड, एंड the cost, similarly the cost is little on the expensive side, and also it is safe medico legally, you can, this is the safer side to use FDA drugs. Razumab is ranibizumab of a different company. Then we have Macugen. Macugen is pigaptinab. Then we have Eylea, that is aflibercept. Then apart from anti-VEGF, the most other common drugs which are used intravitreally are steroids. Steroids में हम Oracort ज़्यादा use करते हैं. I'm just showing you a video how the intravitreal injection is given. यहाँ पे हम pars plana region में जाते हैं और injection inject करते हैं. There are standard landmarks from where it can be given. We use either a 26 gauge needle or a 30 gauge needle. Once the drug is induced, you can just come out. It is a self-sealing wound there. It is given through the conjunctiva. Okay. एंटी वेजेफ हम यूजुअली जैसे मैंने बोला डायबिटिक रेटिनोपैथी में देते हैं, या फिर मैकुलर डिजनरेशन में देते हैं, और फिर वेन ऑक्लूजन्स में देते हैं. दिस इज अ स्मॉल वीडियो, जस्ट लुक एट इट. मैकुलर डिजनरेशन में आपको ओसीटी पिक्चर रहता है, थोड़ा सा ब्लड रह सकता है. ये डायबिटिक रेटिनोपैथी में वेन ऑक्लूजन में है. यूजुअली एज रिलेटेड मैकुलर डिजनरेशन में, डायबिटिक रेटिनोपैथी में, वेन ऑक्लूजन में जो हम इंजेक्शंस देते हैं एंटी VEGF का, सिंगल डोज से काम नहीं बनता है. हमको महीने महीने एटलीस्ट मिनिमम 3 डोजेस हर महीने देने पड़ते हैं. 3 महीने में, 3 महीने में जो सूजन कम होता है उसका इफेक्ट देख के हम लेजर करते हैं, या फिर और थोड़ा इंजेक्शन, मैक्सिमम 3 to 6 इंजेक्शन एक्सटेंड कर सकते हैं. ये इंजेक्शन कैसे देते हैं उसका है. हम ट्यूबरक्यूलिन सिरिंज यूज करते हैं यूजुअली. स्टेराइल टेबल पे द इंजेक्शन इज लोडेड इनटू द ट्यूबरक्यूलिन सिरिंज. द अमाउंट दैट इज यूज्ड इज वेरी मिनिमल. वे मैंने बोला था कि आपको विट्रियस का वॉल्यूम बहुत कम रहता है, 4 ml, तो मैक्सिमम 0.5 ml या फिर 0.3 ml ही ज्यादा है. डोजिंग ड्रग में उसी ml में होते हैं. हर बार हम जब इंजेक्शन देते हैं उसका असर 3 हफ्ते रहता है. उसके बाद हमको ओसीटी करके रेस्पॉन्स देख के रिपीट करना पड़ता है. इंडियन सेटअप में हम यूजुअली इंजेक्शंस ओटी में देते हैं. if you have a really good OPD or a sophisticated, well cleaned, sterile OPD, it can be a OPD procedure also. Most of the injections are given like this. Okay, कुछ दर्द नहीं होता है. One more injection which you need to know is, or the retina counselor will be knowing, is the Ozurdex. जिन लोगों को हम अगर एंटी वेजेफ देते हैं, लाइक एंटी एवास्टिन दिया है या फिर रेजुमैब दिया है, 3 इंजेक्शन के बाद भी अगर हमको लगता है कि उसका द पेशेंट इज नॉट विलिंग फॉर कंटिन्यूअस इंजेक्शंस फॉर अनदर 6 और whatever another 3 injections, उन पेशेंट्स में हम Ozurdex प्रिफर करते हैं, क्योंकि Ozurdex एक इम्प्लांट है. जस्ट लाइक how we gave the intravitreal injection, this implant goes into the vitreous cavity and remains in the cavity for at least 2 months. So उसका ये steroid का है, तो slowly release होता है, sustained release होता है, and the implant remains in the vitreous cavity, and with the slow release of the steroid, IOP उतना ज़्यादा नहीं बढ़ता है, और उसका effect 1.5 months to maximum 2.5 months रहता है. The only risk factor with Ozurdex is you can't repeatedly give Ozurdex. You can't, like same site पे हम नहीं दे सकते, दूसरे साइट पे देना पड़ता है हर बार. So you need to remember the site in which you have given it, and then थोड़ा risk रहता है retinal detachment का. तो because sometimes the implant is really to look it, you can see on the right side how the implant looks. It looks like a pellet. Okay, so it is little large when you're injecting, तो झटके से जा सकता है, या फिर जहां से हम इंजेक्ट कर रहे हैं वहीं पे अटक सकता है, तो थोड़ा केयरफुल रहना पड़ता है विथ इन द फॉलोअप्स. एंड दिस इंजेक्शन वी यूजुअली डोंट रिपीट मल्टीपल टाइम्स, मैक्सिमम 1 टाइम या फिर 2 बार ही देते हैं. So overall, I have covered most of the procedures, okay, as well as the investigations. The only thing that you need to know as a retina counselor is that counseling comes every time the patient is coming to you. Okay, जब पहली बार आ रहा है तब भी काउंसलिंग होगा, हर बार आ रहा है काउंसलिंग होगा, सर्जरी होता है काउंसलिंग होगा, सर्जरी के बाद भी काउंसलिंग होगा. ओके, सो काउंसलिंग and the retina person talking to the patient, giving time more than the procedure is more important in retina. Okay, so consent form हर चीज में रहना चाहिए. Consent form has to be very clear for all the procedures, for all the surgical side, especially on the retina. Procedure clearly mentioned रहना चाहिए. Okay, because medical legally you have to be always safe. And then one more thing what you need to remember is, as I told in the beginning, that the patient, the doctor, and you are the 3 common faces for each other every time the retina patient comes. So there is assume that once there is a retina patient with you, he is your extended family for lifelong. Okay, so it is a long term follow up. Okay, post surgery counseling थोड़े centers में नहीं करते हैं, but post surgery counseling करना जरूरी है. Okay, once the procedure is done, don't become free that मेरा काम खत्म हो गया, अभी डॉक्टर का काम भी खत्म हो गया. It is not like that. You need to have frequent, as I told, post surgery counseling with the retina patient, because you need to sit and talk and make them comfortable with the procedure. Why you need to do it? Because cataract surgery की तरह ये visual outcome बहुत ज्यादा अच्छा नहीं रहता है. Like the wow factor is not there as in your cataract surgery. Cataract करेंगे, cataract निकाल देंगे, उनको बहुत अच्छा दिखता है. You don't even have to do counseling. The patient is already a happy patient. Whereas in retina, it is not like that. How much ever good work you do, the visual outcome is on the negative side. So that is why post surgery counseling is very important, that you sit and talk with the patient, that whatever is done to you is to preserve your vision or restore your vision, and not for the wow factor, or we are not gods to restore your retina back, or the loss of the retinal strength back. ये आपको समझनी पड़ेगी. Thank you.
Yeah, thank you so much,
हाँ
Dr.
सर.
Prathibha. It was a wonderful session. So now let's open it up for question and answers.
Yes sir.
So amongst audience, if you have a question, we have one question in chat box. So I'll take it first. What are these on-label and off-label injections? Somebody wants to know.
Yeah, on label, as I said, that anything which is approved by the Food and Drug Association is on label. जो drugs गवर्नमेंट ऑफ इंडिया या ड्रग एसोसिएशन अप्रूव नहीं करते हैं और फिर भी हम यूज करते हैं, उसको ऑफ लेबल बोलते हैं. इट्स नॉट दैट इट इज रिस्की, इट्स जस्ट दैट इट इज एज इफेक्टिव, बट द अप्रूवल दैट इज नॉट द स्टैंडर्ड ड्रग which is approved. That's all.
Okay, great. Thank you. Any other question? आप अपने आप को अनम्यूट कर सकते हो और क्वेश्चन पूछ सकते हो, या फिर यू कैन जस्ट टाइप इट इन द चैट बॉक्स. Okay, meanwhile, I have a few questions,
हाँ
for the
सर.
benefit of the class. Okay, we'll take this question first. Ma'am, please describe, just a minute. Ma'am, please describe PPV and MP.
Yeah, just give me 2 minutes, I'll just come.
Yeah. Yeah. So meanwhile, we want more and more questions, so don't miss out on this opportunity. बहुत ही यूनिक अपॉर्चुनिटी है. अपने हर एक के प्रैक्टिस में वीआर सर्जन्स आते हैं, बट कई जगह पे फुल टाइम होता है, बट वी डोंट गेट सच अपॉर्चुनिटी टू डिस्कस क्लिनिकल थिंग्स इन डिटेल. या मैम.
Yeah, as I showed you one video where we are making 3 ports and going inside the eye. जो हम आंखों का नॉर्मल जेल जो रहता है, वो जेल निकालने के लिए जो हम करते हैं कटर यूज करके, उसको हम पार्स प्लेना विट्रेक्टमी बोलते हैं. पार्स प्लेना इसलिए बोल रहे हैं क्योंकि द वे आई एंटर्ड, द पोजिशन इन विच आई एम एंटरिंग द आई, that is a pars plana region. So because the bleeding is very less in from that entry zone, that is called as pars plana. So that is why pars plana vitrectomy which is done through the pars plana ports. Membrane peeling is like on the macula. If you are having a membrane, tractional membrane, which is seen on the OCT or which is seen on the lives during the live surgery, we usually stain it with a blue dye or we use a green dye. And then once the stain, or even oracot for that matter, तो स्टेनिंग होता है. स्टेनिंग से वो मेम्ब्रेन और भी अच्छी तरह से दिखते हैं. तो वो मेम्ब्रेन हम पकड़ के उसको पील कर सकते हैं. वो मेम्ब्रेन को जो निकालते हैं हम, उसको मेम्ब्रेन पीलिंग बोलते हैं.
हेलो.
या
गुड इवनिंग मैम.
या
मैम, एक मेरा सवाल था, क्रोनिक आरडी जो है, थोड़ा इसके बारे में कुछ बताएं प्लीज.
देखिए, देर आर फ्रेश आरडीज एंड देर आर क्रॉनिक आरडीज. और फ्रेश आरडी मतलब पेशेंट इज लाइक अभी आज नजर कम हो रहा है, उसको एक पर्दे जैसा दिख रहा है, ही कम्स अर्ली टू अस. फ्रेश आरडी मतलब जो 24 तास 24 घंटे में या 28 घंटे के अंदर जो रेटिनल डिटैचमेंट हुआ रहता है, उसका अगर हम ऑपरेशन करते हैं तो उसका विजुअल रिकवरी बहुत अच्छा रहता है. वेदर इट तो अभी विट्रियस में अभी रेटिनल डिटैचमेंट है, तो मैंने विट्रियस निकाल दिया है, तो विट्रियस के बदले मुझे गैस डालना पड़ेगा या फिर ऑयल डालना पड़ेगा. अगर मैं गैस डालती हूँ तो फ्रेश आरडी में जो जल्दी आया है हमारे पास आरडी होने के बाद, तो उसका रिकवरी 10 या 14 दिन में उसका हो जाता है अगर मैंने गैस डाला है. अगर ऑयल डाला है तो उसका रिकवरी 3 या 4 महीने लगेंगे, क्योंकि ऑयल निकालने के बाद ही उसको दिखेगा. ओके. मगर कभी कभी क्या होता है कि जब पेशेंट जल्दी नहीं आता हमारे पास, उसको रेटिनल डिटैचमेंट हुआ है बोल के ही पता नहीं रहता है. ओके. हमारे पास वो 6 महीने के बाद आता है या फिर 1 साल के बाद आता है. ओके. तो sometimes what happens is we still do the procedure because we want to rescue the eye. Okay. Or we want to still give our best effort by trying our effort and doing it. ओके. या फिर ट्रॉमा में होता है, ट्रॉमा में कॉम्प्लेक्स आरडीज होते हैं, तो हाँ, तो स्पेशली उस तरह के पेशेंट्स में ये क्रॉनिक आरडीज में आ जाते हैं, जहां पे टाइम डिले हो गया है या फिर बहुत ही कॉम्प्लिकेटेड है, कैटरैक्ट है, ट्रॉमा है, एंड मिस हो गया है पेशेंट से डायग्नोसिस. लाइक पेशेंट को पता नहीं चल रहा है कि उसको क्या हुआ है, क्योंकि इंसान के 2 आंख रहते हैं, एक आंख काम नहीं कर रहा है तो उसको पता ही नहीं चला है. या तो वो More than 3 months or more than 6 months, if a patient is having RD and he comes to us, we put it in chronic RDs, or where the RD surgery, even if we do, as a doctor, I'm not expecting good response like in a fresh RD. Okay, तो chronic RD हम उसको बोलते हैं.
जी थैंक यू मैम.
हाँ.
Yeah. So what a question I had was, uh, in case of freshly diagnosed, we are patients.
हाँ sir.
To what extent do you recommend involving counselors? मतलब we are surgeon ने कितना explanation देना चाहिए और counselor का role कितना होना चाहिए?
See, according to me, for retina, as I told you that though we will have only 10 or 15 patients or 20, 25 patients per day, the time duration which we are spending time with the patient is more per patient. तो मेरे हिसाब से whenever the patient is there has to be a OPD counselor, there has to be a surgical counselor for retina. Okay, because I want my counselor to be there with me in the OPD, especially for retina, because what I have told to one patient, it may be documented, but the patient is not understanding your medical terms. He is not understanding the seriousness of it. Okay, उनको वो seriousness रहती नहीं है, because it is not a simple procedure like cataract. That retina exists, और आंख ऐसा है, उनको पता नहीं रहता है. So explaining the pictures, I would have done FFA. I would have explained. Probably the patient needs some more explanation. So I want a OPD counselor and I want a surgical counselor separately. OPD counselor will help me in help the patient in understanding the procedure, whatever is done, whether it is FFA or whether it is OCT or whether it is B scan. Repeatability of what you have done to the patient is more important in retina, so that, because what happens is, in the expectation level for retinal diseases are different. अगर उनको visual outcome ही अगर उनका expectation है, then the patient will do shopping. Like, he may not be happy with you what you have told, so he will go to 10 other doctors, wasting his time and energy and money. So more important is, whenever a retina patient comes to you, you put your best effort in telling them what you have done. What is being done is the same thing which will be done anywhere you go. You need to trust the doctor for the treatment which we will provide you. That is more important. Counselors are integral part of retina. Doctor does the talking, but counselors, as I told, I need a OPD counselor differently for the procedures, and surgical counselor differently.
Okay, great. See, many of the centers have visiting VR consultants. So, gelling up, or I would say the rapport between a visiting consultant and in-house counselor becomes an issue many a times. So what would you suggest? I mean, as you said, counseling is integral part of retina. So, many a times today we are taking efforts and, equipping them with the knowledge, but then procedures or the way it has to be explained varies from person to person, practice to practice. So this problem I have seen many centers are facing, that because the consultant is visiting, there is not much enough rapport between counselor, and in the bargain what happens is the consultant ends up counseling and explaining the whole thing. So how would you address such issue?
See, if you have a in-house retina person, you don't have much problem. But as you said, if you are having more of visiting consultant, then I would suggest them to get involved with the hospital staff. They need to have a rapport, because otherwise it is going to be tough. The chair time which you give as a doctor to the patient will be very high, and the chances of losing the patient will be more. Your VR practice over long term may not be as effective as you want it to be. I think there is a major disadvantage with visiting consultants like that. Probably everybody will realize that now.
Yeah, but it's very difficult to hire a full-time VR surgeon at every practice, especially
No,
solo
but then,
practice. Yeah.
sir, see, but your retina practice is at least 75% medical retina. Huh? 25% is surgical work. So the doctors who are there in house with you, whether it is anterior segment surgeon or a cataract surgeon or a glaucoma surgeon, they are very well knowledgeable for medical retina part. I think some part of that job can be taken up by them, because initially the primary doctor, whomever they are meeting, they are going to be anterior segment people or the glaucoma specialist or somebody. So that little bit of trust building, what has to happen, can happen.
Right. Do you have any other questions? Okay. One more, very common question that comes in counselor's mind. A consultant simply says, explain him, under GBP.
Huh.
So, a non-medico or non-clinical person is confused. How much guarded a counselor has to be? I mean, many a times they end up explaining in detail that the patient has question about the outcome in his mind or her mind. So how much guarded they need to be while explaining? The prognosis is really guarded or not predictable.
Yeah. See, once the patient has come to us, we have the initial workup sheet with us. Okay. In that, the vision is mentioned. Okay. Whatever the vision he is having at that time, it is mentioned. So that is the standard for you now. Like if the patient had 612 vision, like a diabetic retinopathy patient is there, and his initial checkup has happened, and his starting vision is 612 in both the eyes. So you should tell them, like as a counselor or as a doctor, my job is to tell him that, okay, fine. Among all the lines, you have lost 2 lines of vision. 2 line of vision is less in you. Okay, this may remain, or with the procedure, whatever we do, it may improve. That is the way to take it. Rather than telling that you will lose your whole vision or you will get back your whole vision. Visual acuity recording whatever has happened in the initial assessment, that should be your guideline. If he is having 660, assume that he is having only 660. You should tell him that you have lost 6 lines of your vision, standard vision. So you may regain few lines. You may not regain, or you will maintain whatever is maintained in the as you are seeing. That should be the way of talking.
Yeah, that's very good point. I mean, the reference point of visual acuity is a wonderful
Yeah.
tool. I mean, many times we are confused. How do we explain? I mean, what are going to be the outcomes or what outcomes to expect? So that's a wonderful referral point, I would say.
Yeah.
Many counselors, while explaining procedures, I have seen using words or terminologies like jala denge, in terms of
Yeah.
laser. So can
Yeah.
you give a few examples what to say and what not to say?
See, what you should do is, as I said, that for lasers, what you can do is, you are, instead of using that, जलाएंगे, you can tell them that you are sealing it. चिपका रहे हैं, और वो चिपका जो रहे हैं, वो थोड़ा सा हीट देके, लाइक शेक देके कर रहे हैं. हम अंदर नहीं जा सकते, इसलिए एक लेजर मशीन रहता है. यूज सिंपल टर्म्स सो दैट द पेशेंट नॉट डजंट गेट स्केर्ड.
Yeah, correct. So any other question from the audience? Or else we'll have to wind up early. We have around 50 minutes more. Yeah, 1 hour more. So utilize this time. So I think they are. Yeah,
I think they're happy.
Yeah, I can see one raised hand. Varsha Tapadia, you
Yes.
can unmute yourself and ask question.
Okay. So many a times I am an anterior segment surgeon and I have a visiting consultant. So most of the time, even if he does counseling, patient come back to me and it's most about the intravitreal injections. So their question is about इतना महंगा इंजेक्शन है और कुछ गारंटी भी नहीं दे रहे हैं, फिर क्यों करना है? So as an anterior segment surgeon, I can explain to them. But other counselors, even if my staff wants to tell them, so what should be the way to counsel them so that they agree for the treatment?
Yeah. See, now assume that you are having a patient who is having diabetic macular edema. Okay. Now, अभी diabetic macular edema है. Now, इसका vision इतना है. Like, assume that it is 612. Now you have the facility of only fundus camera, assume that. Okay, fundus camera में आपने एक photo निकाला है. You can show him definitely on fundus camera also. You can show the difference between a normal eye and the abnormal eye. Okay, definitely, because you're not having OCT, you're not able to quantify the edema which is there. Okay, still you can
No, we
through the
have
fundus
OCT also, so that.
Okay, if you have OCT, do the OCT, quantify it. Okay, now assume normal thickness is somewhere between 250 to 300 microns. Okay, let us be as technical as
Yes.
possible. Okay, so assume that the patient is having only 380 microns या फिर 400 microns. Okay, in the center of the macula. So you can tell him that, you know, normal thickness is this much, normal retina is this much thickness. Yours retina, because you are having diabetes, is showing swelling like this, and the swelling is at least of 100 microns more. तो इसको नीचे करने का एक ही उपाय है, that is you have to take injection, and the injection once it is given, the effect remains in your eye for at least 3 weeks. So only because the injection is acting on you for 3 weeks doesn't mean that your vision will recover immediately. You know, sometimes you will need repeated injections, maximum 2. And with one injection, if we are having a good response, still we may repeat the second injection, so that because we don't have rebound edema, okay, which will eventually happen if he is not keeping his sugars under control. Okay, so as a doctor or as a technical person or as a non-medical, like, you know, counselors, you still stick, that is why I said stick to the reports that is available with you. Look at the reports more than the patient. The reports are there to help you when you are talking to the patient, so that it's not that it is a make-believe system. Everything is there in front of you. What is there in front of you, you also need to believe that, you know. Only then the patient will believe,
Yes.
okay, fine, this is how they are planning. It is it is quite okay. You know, I feel anybody who is running the center, the main counselors and the main doctor should get involved in the medical retina part.
Okay.
Yeah.
All right. Thank you.
Yeah.
Yeah. Any other question? Ma'am, see, as far as these, diagnostic investigations are concerned, say, I mean, you know, many a times visiting, this happens especially in case of visiting VR consultant. You know, he or she says, she advises, let us say she has advised injection or some procedure, but then, you know, they ask, it's better to get a referral OCT done. So that time for counselor it becomes very difficult to explain. So how do we explain such things? ये कैसे explain करेंगे कि ये OCT क्यों करवा रहे हैं? Because that costs. So, you know, many patients have this thing in mind.
Yeah. See, one thing is whether you have OCT or you don't have OCT, documentation is important. Okay, whether you are keeping the documentation in terms of whatever the doctor is saying. Some doctors, if they don't have anything, they keep it as a documentation with the fundus drawing. Okay, handwritten. But then, if you have a good MOU which is nearby, where your OCT, like, you know, you don't have OCT, but you want to utilize the OCT facilities, either you will have to convince that the patient has to go there for once. Either you decide whether you want the OCT before treatment or after treatment. Because अगर मेरे सेंटर में मेरे पास OCT है, तो मैं प्रोसीजर करने से पहले करती हूँ और उसके चार्जेस लगते हैं. मगर मैं इंजेक्शन देने के बाद फॉलो अप में हम चार्ज नहीं करते हैं. दैट इज द एडवांटेज that I take of the machine which is available with me, because he has already paid for the procedure, and pre-op I have already done that and I have already charged. So post-op follow-up, usually we don't charge for the first and the second follow-up. Third follow-up हम charge करते हैं. Okay, but now since you don't have a OCT machine, you decide where. See, now you already have clinical diagnosis already ho gaya hai. Okay, so one advantage what you can give to the patient is, you know that as a doctor, you know that this patient needs injection because the visual acuity has come down. Okay, so instead of going for a OCT before the procedure, I would advise go for the OCT after the procedure, especially after the drug response. Injection देने के बाद एक 10 दिन के बाद OCT करा लो, because you will know that whether the drug is acting on it or not, whether the second dose is required or not. You know, I would prefer, if I don't have a OCT machine, I would prefer doing a OCT after the procedure, referring the patient to some other center after the procedure.
Yeah, great. So I think Yeah, there is one more question from Swati Mehra. Can you please throw some light on piggyback IOLs, also about IOLs in sulcus in PCC from a counselor's point of view? That's a very good question.
See, usually most of the anterior segment people are efficient enough to manage their complications. Okay, but sometimes a posterior segment surgeon manages the cataract complications. Okay, so whenever a cataract surgeon is not able to put the lens in the bag because the PC is compromised, because the posterior capsule is compromised, he will put the lens in the sulcus. Sulcus matlab iris है, iris के पीछे capsule आता है. Okay, there is a space between the capsule and the iris, so that space is sulcus. Okay, now समझो कि sulcus भी compromise हो गया है. Then we have the option of secondary IOL. Secondary IOL matlab either a anterior segment AC IOL or a scleral fixated IOL. AC IOL में क्या होता है? I am placing a lens in front of the iris. Okay, so that will be seen through your cornea. The lens can be seen completely through your cornea, just like your iris. It is because the anterior chamber IOL is placed in the front of iris, whereas scleral fixated, like we have different types of lenses. Scleral fixated, like with a suture, I am attaching a lens to the pars plana region, so that is scleral fixated. This option of ACIOL and scleral fixated comes only if there is a loss of capsule and there is normally जहां पे हमको lens place करना है वो जगह कमजोर पड़ गया है, then only then we will use ACIOL or a scleral fixated IOL. Whereas piggyback IOL is not frequently done. Okay, it is not a common procedure. Piggyback IOL कब करते हैं? Now there are two ways of thinking. एक तो IOL power इतना ज्यादा है कि वो customized IOL में भी नहीं बैठ रहा है. Like we are not able to order a customized lens. Okay, especially piggyback IOL का concept कब आया था? जिसको hypermetrop है या फिर जिसका आंख बहुत छोटा है, उसका power बहुत ज्यादा रहता है. Like you know, somewhere around +30, +27, +32. So those type of lenses are not customizable as well as not easily available. तो हम लोग क्या करते थे? +25 का लेंस डालते थे या फिर अगर 30 डायप्टर्स का है तो +20 और +10 ऐसे पिगीबैक कॉम्बिनेशन करके वो लेंस डालते थे. बट वो पिगीबैक लेंस डालना है तो एक लेंस बैग में बैठेगा, एक लेंस सल्कस में बैठेगा. Okay, so for that there is a narrow space. There should not be overcrowding because I'm putting two lenses. The space should not overcrowd. तो इसलिए हम पहले यूबीएम करते थे. यूबीएम करने के बाद जगह का जो जगह है वो नॉर्मल है कि नहीं वो देखने के बाद दो लेंस बिठाने से ग्लोकोमा नहीं होना चाहिए. You know, the patient should not end up in having glaucoma. So that is why only very few people who fit into that procedure, piggyback was done, especially for high plus numbers. अभी क्या है? Nowadays people are having sulcoflex lenses. Sulcoflex lenses are what? I have put a regularly हम A scan करते हैं. A scan करने के बाद लेंस बिठाया है. Whenever we do a A scan, हमारा aim क्या रहता है? ऑपरेशन के बाद the distance power should be 6 or there should be 0 power. Okay, sometimes you have refractive surprise, either because you have not done the A scan properly or the eye of the person has reacted like that and you have a refractive surprise. तो अभी समझो कि मैंने +20 का लेंस डाला है. +20 से अगर मुझे -10 या -7 डायोप्टर्स का डिफरेंस आ रहा है पोस्ट ऑप और उसका विजन उतना इंप्रूवमेंट नहीं हुआ है एंड आई एम हैविंग अ हाई रिफ्रैक्टिव एरर पोस्ट ऑप, मतलब मुझे उतना नंबर उसको चश्मा देना पड़ेगा. -5 diopters, -6 diopters. So now we have the option of sulcoflex lenses which are foldable and which are thinner, which can be placed to recover your post-op refractive errors. So that lens is also placed in the sulcus if you have placed your initial lens in the bag. So this concept is like, you know, also like a piggyback concept. So ये दो है.
Yeah, he's asking, but since it's risky,
Yeah, this is risky. That is what I told you. Once the IOL is put in the bag, most important thing is doing UBM or a anterior segment OCT. Check for the space, anterior and angle का depth कैसा है, anterior chamber depth कितना है, posterior chamber में तुमको space कितना मिल रहा है, you know, only then you decide, because lens डालने के बाद you know you are taking, you should not, I told you that it should not overcrowd your space and you should not end up in having glaucoma. It was any time better that he had used the glasses rather than having glaucoma and then using the drops for lifelong. Okay, but as I said, sulcoflex lenses are coming as very thin lenses because the periphery is thin, only the central optic has the power, that will be thick. Okay, so that will not cause much damage.
Yep. Any other question from the participants? One last question from my end, ma'am. Yeah.
Sir.
Let's answer Swati's question first.
What is this? In this case, this has to be a resurgery. See, sometimes what happens, it is not resurgery. It is like, you know, okay, fine, I've had, see, you can put it as resurgery. No, then never mind. You can put it as a second procedure also. Okay. Sometimes what happens is sulcoflex lenses हम जब डालेंगे तो हम थोड़ा सा vitrectomy भी करते हैं ताकि space बढ़ जाए. Okay, so you can put it as second procedure, and everything whatever you are doing will be mentioned in the consent form.
No, probably what she wants to ask is, since this is a resurgery, it will attract cost. So how do we counsel?
Of course.
How do we counsel?
No. Yeah, how do we counsel? See, you will have to go back from where you started. Okay, so when the patient came, what all things you have done, you know, there is no harm in telling that this is what has happened to your eye. You don't have to tell that we have gone wrong. That is not how it is put. You will have to say that we did the regular A scan. सब लोगों में हम A scan करते हैं. आपका power इतना निकला था. सब लोगों में जैसे ऑपरेशन होता है, आप में के आंख में भी ऑपरेशन हुआ था और लेंस हमने बैग में ही बिठाया है. But in spite of that, we are having a refractive surprise like this, which we don't see in most of the patient. In you, it is found. So there are two options. Either we go and put one more lens there, okay, which will avoid you from using glasses of very high power. Okay, and at the same time, because we are doing it, it will cost you something. Okay, so whatever charges are there, you will have to tell them. Yeah,
right. I mean, it's always better to be as transparent as possible. I mean, right
correct,
from day one.
Correct.
So if you are, I mean, you know, the day you come across the surprise and you start hiding, then it becomes very difficult to counsel later on. It's always better to be transparent right from day one.
Correct.
So, thank you. A last question from my end, though you have explained during your session. See, in case of intravitreal injections, I mean, there are a lot of options with varying costs. So many times we come across this difficulty. How do we, counsel for these various options, and what do we say? Apart from efficacy and the US FDA label, is there anything that we can explain to the patient in terms of setting? Is there any differentiation?
Yeah, see, what you can do is, when the patient has come to us, the way we are talking to the patient, we come to know about their educational status. We understand how much they understand what we are telling. Okay. Third thing is, we are all judging whether he can afford it or not. Okay. Fourth thing is, assume that they have insurance with them. Then we know how to cover it. Okay. Otherwise, assume that the patient needs treatment, but the patient does not want to go for Razumab. Razumab costs you per injection, costs you 18,000 to 20,000, whereas Avastin costs you 8,000 rupees. Okay, 8,000 to 10,000 rupees, or some centers 12,000 rupees. Okay, now if there is a patient who is really financially not sound, according to me, I would still go for Avastin. I will straight away, the decision making is on the doctor's side. Okay, the rapport that I build with the patient. If I feel that the patient is not able to decide what is good for him and what is not good for him, okay, the safest drug is always FDA approved drugs. But he says that I can't afford that. For me, what is more important for the patient is that he completes the treatment. Instead of he shelling out his money on one single dose of Razumab, if he is ready to complete the whole course of 3 doses with Avastin as well as take the laser later, because in retina you can't tell that pehle ye injection karao baad mein hum dekhenge. Don't do that. You have to tell him that you will need minimum 3 injections, and after this I am planning for laser. Your treatment protocol will go for 3 months. The planning for you is like for over 3 months. The laser, even if there is laser in injection laser involved, you will have to tell that the injections will be 3, and we will give it to you in 3 months. And if there is laser, we will do it in 3 or 4 sittings. The cost has to be told in the beginning of the treatment. Don't keep them waiting. Don't keep them assuming things. So if they're overall, like, because the charges are going to come for them for both the eyes. So assume that I'm giving Avastin for 10,000 rupees, and he will, according to the protocol of the treatment, he has to take 3 injections. It will cost him 30,000 rupees. Okay. Assume that I want to give 2 sitting of laser. So 5,000 rupees per sitting laser, 10,000 rupees. So overall for one eye, he will have to shell around 40,000 rupees. Okay. Over the period of 3 months. So this has to be explained. And if he's having bilateral, then you will have to be very clear about the expenditure which is coming up, because we can't keep talking about the cost every time. We can't keep, because you're giving chair time of 3 to 4 hours. When you're giving 3 to 4 hours, sit and talk everything clearly in the beginning, because it will put across the things very clearly across the table. And especially when you're putting across things financially, you always, with the family or with the patient, keep the decision maker in the room. Like, assume that the father is affected, but the son is going to pay for the procedure. The son is going to decide. Somebody else, whoever is paying, is the decision maker. So that person has to be there physically or on call, so that he knows that this is how it is going to happen.
Right. Thank you. So if we do not have any other question, we'll conclude with the session.
Yeah.
And last reminder, if you have any question, you can ask it now before we conclude. No, I think it was a wonderful session, Dr. Prathibha.
Thank you, sir.
As usual, thank you so much. And now we request you to share your PPT with Ophthal people, so that we can share it in the participants group. And even after this, if you have any question, you can simply forward it to Ophthal people, and we'll try and get answers from the delegates. Right? So thank you all.
Yeah.
Thank you, Dr. Prathibha, for your valuable
Thank
time.
you, sir.
Wonderful 2 sessions last week and this week.
Thank you, Pratik, sir. Bye.
Good night.
Thank you so much, Doctor.
Bye.
Thank you so much for your valuable session in the 2 sessions. It will very much.
Yeah, thank you, sir.
Doctor. Thank you so much.
Thank you, Hari, sir. Yeah, bye.